Hello, welcome to On Becoming a Healer. For a lot of people today, primary care refers to some doctor assigned to you in a health plan who you may or may not see, who may or may not know you, and it's their office you call when you think you need a referral. But originally, and for some people still today, primary care is the doctor you see first, that person who knows the full picture of you and your health and what you're dealing with in your life. And then they coordinate, make sure that the specialists you might need don't lose the thread. It's the kind of care that today a lot of people think is in crisis. Well, let me just allude to a few of the problems highlighted in a recent series of articles in the New England Journal of Medicine that describe how the primary care doctor's job is a bit of a mess right now. Shorter visits, an unmanageable inbox of alerts, massive burden from the electronic medical record, and they're measured to death for whether they've ordered all the screenings or fulfilled any number of dozens of preventive health tests. Almost none of them have anything to do with whether the patient is taken care of when he or she is sick. And primary care doctors feel like they're the low people on the totem pole. So that set of articles in the New England Journal of Medicine got us thinking. We're going to dive deep, but we're going to do it in part through the eyes of a wonderful guest who I will introduce in a moment, Dr. John Scala. But first, I'd like to ask my co-host, Saul, to speak on this. Hi, Saul.
Hi, Stefan.
Saul, can you tell us why you thought we should take a close look at that series of articles from the New England Journal and do it through the eyes of a doctor who's in practice and in many ways a model for us?
So I think that Dr. Rosenbaum does a good job of hitting on a lot of the issues that you were just touching on yourself. She talks about, the structural harms that have been degrading primary care, including underinvestment, these kind of metric distortions where doctors are constantly beholden to measuring things, or I would say meeting metrics, the kind of cultural devaluation of primary care, what is sometimes referred to as mission creep, just having to take on an increasing number of responsibilities that may not require a doctor's skills. She gives examples of all the productivity pressures, of panel size, inbox burden, all the emails that we get, just the whole corporatization of the system. And while I think that's important to talk about, what troubles me is the direction in which she takes it. She opens the series with the following question. She writes, as medical knowledge balloons, leading to more costly care requiring hyper-specialized expertise, a difficult question arises. Has the long-term general doctor become obsolete? In other words, she asks, should the dying primary care system be saved? And this question comes up repeatedly in her essays. At one point, Dr. Rosenbaum quotes a family physician, well-known scholar Kurt Stange, who wonders out loud whether, quote, primary care has had a good run. And elsewhere, she herself writes that the archetypical PCP is, quote, a vanishing breed. And finally, in her last essay, she writes, quote, I'm still not sure how to save primary care. On some days, I suspect it may need a complete collapse before it can be effectively rebuilt. Now, while I support asking challenging questions, I think, at least to me, these questions, particularly when they're repeated so many times, feel like a sort of capitulation to a system that has been obviously very hard on primary care, that has been hyper-focused on specialization, on productivity. And while I think the concerns that are raised are really important to talk about, I don't think the key question, at least my view, is should we just let the whole thing go? I think the question is something she brings up in her last sentence of her final essay. She writes, who do we as a profession want to be? And one of the reasons I wanted to bring on Dr. Scala today is because I think in many ways, at least in my view, he's the answer to that question. And we'll learn more about that. I think some of you may recall, if you've been following us for a while, that back in 2020, we did 2 episodes on John and his practice in the midst of the pandemic. I recommend you go back and listen to those if you're interested in getting a deep picture of what meaningful primary care looks like. But I met John, and again, you'll introduce him, but I met him many years ago. Actually, he was one of the first residents when I was a program director in my early stages, way back in the 90s. And, I just have to mention one story about John from back then. This was before there were duty hour restrictions. And I recall that post-clinic, our residents would sometimes have to straggle back up to the floor to finish up caring for the patients when they'd been up all night and all the previous day. And it's just exhausting. And John, when he wasn't post-call, would brightly say, hey, anyone want help? I can go up there and with you and help get you out earlier. And I have to say, after watching residents for over 25 years, I've just never seen a resident do that. But I don't think John is unique in the sense that there isn't anyone else out there like him. I think there are many primary care physicians who deeply enjoy and find meaning in their work. And I think that has to be the focus. The focus really has to be on how do we make that happen more? And we have to talk not only about the structural issues that are making it so hard to practice primary care, but I think we have to take a look at ourselves as well. Like, what is it about our profession that we produce few people that become this, that want it, become it, embrace it? When I sent an email to John about being on this episode, I wrote back, quote, "There's so much money in healthcare and primary care just gets squeezed and dumped on. I don't really think about it anymore, though. I just do the best I can every day, and I don't care what the cardiologists and plastic surgeons and dermatologists earn. I chose a profession based on my initial values and skill set, and those principles still hold. It's a lot of work, and I would have made a lot more money in business or finance or some specialty medical care. I could switch to concierge and skim the top off the rich people, but I'd probably lose most of my pediatric practice. I don't really want to deal with the concierge crowd. It can be good medicine, but there's a lot of system manipulation and sucking up to address the needs and whims of entitled people. A lot of the business people I take care of, they retire at 55 or 60. I'll be 57 in April this year, but I like working. I feel that I'm providing a good service to the community. I'm just so grateful every day that I've been given the gift to help and heal. And every day I tell myself these things, and it makes the career so much more rewarding." So again, to me, the right question we should be asking is, why aren't there more physicians like John? Where are we failing in the process of selecting who goes to medical school and the culture within medical school and the residency programs? Before I turn it back to you, Stefan, I just want to pose a question here. Who among us, particularly as we get older and we start having health problems, doesn't want and doesn't need a competent, caring health professional who knows us, who cares about us, who can help us navigate a system that is sometimes predatory, who we can turn to for advice and guidance with our health and our healthcare? How can we possibly imagine a functional, healthy, healing profession without someone like that at its center? Who among us doesn't want that? Who among us doesn't need it? And to me, the real debate should be, how do we make that happen? How do we preserve it? Thanks, Stefan. Back to you.
Thanks, Son. At the end there, I was thinking of my two aging parents and how much I want that for them and how worried I am that that is not available to them. So our guest, Dr. John Scala, completed a biomedical engineering degree at Johns Hopkins in the 90s. He then went to medical school at the University of Illinois College of Medicine, graduating in 1995, proceeding to a residency in internal medicine and pediatrics combined, where he met our co-host, Saul Weiner. He's practiced for 27 years total. 19 years of those have been in solo practice. And today he practices, as he has for many years, in Centennial, Colorado. And it's his own practice. John, thanks so much for coming on.
Well, thank you, Stefan.
I would love to just hear a little bit about whether you had a vision. How did you wind up where you are?
Yeah, I was in biomedical engineering, and being at Hopkins, I didn't think I was really that good of an engineer. So I was starting to look at other options. And then, honestly, a show came on TV. You guys might or might not remember. It was called Northern Exposure.
Mm-hmm.
And it was about this guy from New York, and the state of Alaska had paid for his med school. So he was obligated to work in Alaska for 4 or 5 years. And so he thought he was going to work in Anchorage, but he got stuck in this small town, and he took care of all of them, and he had to do everything. And so that came out in 1990. I was a junior in college at the time. I'm like, that's so cool. I said, I want to be that guy. And, and that's where it's gone. But, I thought that, and granted, this was 30 some years ago. Primary care was the best use of my skills. I wasn't real coordinated, and, I thought surgery would be difficult for me. But to be able to practice in a deeply cognitive type situation on a daily basis where you're learning every day, and theoretically, you could do it for a long time. If you take care of yourself and your brain is still functioning well, your body could be wearing out, but you could still be treating patients, in your 60s or 70s or even later.
Yeah. Okay. So there is a bit of a vision there from the start. I think it's common these days for people to seek a job with a large organization that provides a kind of fixed salary, fixed incentive structure. And you didn't do that. Was that clear cut to you right at the start, or like what led you to do something that maybe a lot of people wouldn't even try?
Well, so actually, the way it turned out is I was working my first 2 years at a outpatient hospital-owned group in Massachusetts because my wife was doing some of her training out there. And so after that, we had to move out to rural Utah because my wife was a foreign medical graduate and there were some visa issues. And the only option for me at that point was they said, we'll give you an income guarantee, but you have to have your own practice.
Hmm.
And so, back then it was more difficult to change jobs. There was no internet and stuff. We're talking like 2000, 2001. So when you move to a new place, if you're going to start a business, the first thing you do is you like call White Pages or Yellow Pages and order a phone book
Yeah.
and they mail it to you. And then you start, finding all the contacts that you need for, a cross country move like that. So it was pretty challenging for a guy that was 31, 32 years of age. But, it turned out all right. And I kind of got the hang of it after a couple like IRS type letters. And each subsequent time when I started both in Illinois and here in Colorado has been easier. In fact, this last startup, it was a breeze. And even since then, I've guided several other physicians in their own startups. So yeah.
Tell me a little bit about your practice right now. Is there a building? Where is it? Who's in it? What's going on each day there?
Right. So this is a just kind of older type building. I think it was built in the early 80s, half falling apart maybe. Something's always broken. And so, yeah, I rented a space here and it was a decent deal compared to the newer fancy buildings that most of the other doctors in the area, the hospital-based doctors have. And since I've been here, it's become all medical. And so, there's like a physical therapy on the first floor, and across the hall there's an internal medicine group, and next to me there's a family practice group. But they keep getting smaller and smaller, the primary cares, because people are retiring and so on. So we just have a really small office. It's 1,300 square feet. There's 3 exam rooms. My nurse practitioner who came on about 3 years ago, she sits in the same room as me here, and at least we have a window, so that's good. And it's just kind of a simple setup. It's not fancy at all. But there's like no phone tree with my front desk. We answer the calls. They pass it back to me. I talk to them. It's just kind of like the old way of doing things.
Yeah, that's interesting. There's this couple of lines for that set of articles we referred to where primary care doctors describe working in systems where there's maybe paid staff who run according to an algorithm and actually get in the way of the patient ever getting to their doctor to get something handled or get a question answered. They're kind of shunted around through a system. Sounds like people have pretty direct access to you.
Yes. They can leave a message here with the receptionist or the office manager, and then I can call them back. Or sometimes I'll have the medical assistant call them. But yeah, so a lot of the main big hospitals around here, there's a centralized phone system of some sort.
Yeah, that's what I was thinking.
The phones don't come to the office, and then they schedule if they think it's appropriate. And then the bean counters in the accounting thing make sure all the scheduled slots are full. And so the physician doesn't know if maybe one of their patients is sick and they can't get in and you can't squeeze them in afterwards. But here we don't do any of that. I have a system where we leave 4 to 8 same day slots open, and just about everyone can be seen on the same day if they call in the morning, and it's very convenient for them.
I guess I would ask how you see kids and adults, and
Right.
I know that's a lot of very different kinds of work, but how many might you see in a day?
So yeah, so my half days I'll see 10 to 12, and
Yeah.
then my full days 15 to 18. And we'll get into it later. I'm not killing it on the revenue side, but
Got it. You're not. Yeah, that sounds. I mean, I almost might be able to survive that.
Right.
And
Right.
I'm not a very fast clinician, so I'm struck by that.
Right. But the
Yeah.
thought is that if I don't kill myself going through, I could work longer and enjoy it while I'm going through.
Enjoy it. Okay. And that is a theme we're going to come back to too. What do you enjoy? What do you actually like in all of this?
In medicine,
Yeah, exactly.
well, I like just about all of it. I mean, I have a very close relationship to most of my patients. It's hard to remember names, but it's really easy to remember stories. So I have a story about every patient based on maybe their grandkids or the kind of work they did, or if they were in the military or their hobbies sometimes. And so we chat about these things as part of, it only takes an extra minute, and it's so much more important than all these check boxes and so on. Take an extra minute, ask them about something in their life. And it's just so rewarding on a daily basis to kind of grow and learn about these people. I heard from another doc, they learn more about their patient from the obituary in the newspaper than they ever had from
Oh my
talking to me.
God.
And so I didn't want to be that guy.
I so appreciate that. Kids too. So, I mean, do you think about your kids, the kids that you take care of in a different way? I mean, do you get to know them per se, or is it their parents? What's that? I mean, keep
Absolutely.
in mind, I'm an adult internist. I'm not a pediatrician.
Right. And so it's both. Part of it is focusing on the whole family unit. So it's exciting to have a newborn, but mom is exhausted and dad's standing around. And so we work it as a family unit. And that's very appreciated by, I bet all pediatricians do this also. And then once kids get old enough, 4 or 5, I talk to them directly. It's not just talking to the parent. And a lot of parents really appreciate that. And I think the kids do too.
When you have to get services of various kinds, you're interacting with the world out there, specialists. I don't know, with surgical cognitive specialists like rheumatologists or dialysis or something. What happens when you, the solo practitioner, go into the world and then there's payers and systems? Does your solo practice have the wherewithal to navigate this bureaucratic world that we live in?
Yeah, to the most part, we do that. It's a rare case where we can't find a decent specialist within an insurance company. The hardest ones actually are the Medicare Advantage. Okay.
What's Medicare Advantage, just in case people listening
Right.
don't know that?
So there's standard Medicare, and that's where, you can basically go anywhere. Then Medicare Advantage is like an HMO, and they have only certain contracted physicians. These Medicare Advantage programs have been co-opted by private equity now,
Yes.
and so they restrict the patient.
I I spent a certain amount of my time hearing from other doctors, sometimes on social media, but also just talking to people. And they're like, my life is a hellhole. I'm fighting. They never let me do what I need to do for my patient. It's terrible out there. Why aren't you saying that?
So this is how I look at it. So, if you talk to enough other people, every job has its ups and its downs, huh? Right?
Yeah.
So, from the guy that's waiting tables at the bar next door to my building, there's certain parts of his job that are really annoying. And there's certain parts of his job that he probably really likes. And same with the guy who's my auto mechanic and so on. So every job has things that are annoying and things that are really rewarding. And it's not like when you go to an amusement park, you're paying to have fun. There's a reason they pay you for working, right? Because it's work.
My
It's not an
God.
amusement park, right? And so, that's how you look at it. And so it's annoying to do prior authorizations, and I have some strict guidelines with that. I don't do prior authorizations for sleeping pills or like ED pills, or there's a certain set of things that we don't do. And then, it's annoying to sometimes deal with the insurance companies. It's annoying to do this. But then on the other hand, I just had, 10 great conversations today with people that I've known for a while. And I met a new guy and his life is kind of cool and interesting. And so I think the positives, at least the way I look at it, way out, they super outweigh the negatives. Every
Wow.
job has annoyances.
And I was really digging for you to say it's a hellhole out there. Let me tell you, I didn't hear it.
Now, that being said, Stefan, when we moved to Colorado, I worked 6 years for one of the large organizations.
Okay.
And there's a reason I went back on my own again. It would have been a lot easier and granted a lot better pay
Okay.
to stay with them. The health insurance is better. The 401k is not better because I've got a good one, but the health insurance is better. The pay was a lot better. We're talking, at least 50 to 60% better pay to
Okay.
stay with the big company. But the layers of management, the just no control over the situation. It was too much. And, as primary care, once you get a good medical assistant or nurse trained, what do? They give it to the new neurosurgeon because he's the cool guy.
Oh, interesting.
Yeah.
So you
Every
lose
time
that
it
staff.
happens.
You lose that
Huh?
staff.
You lose that staff once they're all trained up and you're working and you're kind of smooth because, it's kind of a high volume thing. So you lose that staff and they go to the specialist because that guy, he's obviously more cool than me. And then you get another grad and you have to train them up again. And so you never get into a good flow. And they're talking about productivity and this and that. And as it worked out, there was a time with that organization that our clinic got some award because we were the highest producing clinic whole nationwide for this big healthcare organization. But, honestly, it's just a stepping stone for us to refer to increase the revenues in other departments like, surgery and especially orthopedics. That's a big one where there's a lot of money. Radiology, of course, cardiology, and so on. So there's only so much I could take. And I don't know. In terms of restrictive covenant, with all their lawyers, the last time I renegotiated the contract, I had them put a clause in there that if I go completely independent, there's no restrictive covenant. And so they thought I was bluffing, but then I did. So a lot of patients came over.
Did you read those articles that we referred to by Dr. Rosenbaum in New England Journal of Medicine, where she talked about primary care in distress?
Yes, I read all the articles. They're quite interesting.
So, for instance, quality measures, they often measure things that aren't really core to care, like that we're becoming box checkers and maybe not taking care of our patients. Did you identify with it, or did you feel like you've escaped that by creating your own path?
If I followed the entire U.S. Preventative Task Force guidelines, there wouldn't be any time to ask about the guy's grandchildren. Isn't that more important for a senior?
Yeah, I think
Right?
so.
No, because you know what? When I ask him that, he knows that I really care about what's going on with his life. Okay. We're in Colorado. If I talk to him about guns and there's no kids at home, he doesn't care about that. So to be honest, I just do the screening that affects my Medicare payment at the end of the year. And so that, I have to record like the colonoscopy and the mammogram. And then I want to know how they're living at home, especially the seniors. 45-year-old guy that comes in, you don't have to worry about that in most cases. But what do they do for their meals? In the wintertime, when it's snowy, can they get out and get their meals? Can they go to the grocery store? Have they fallen in the last 6 months? And the incontinence one's important, men getting up at night to urinate. So I kind of pick and choose, and a lot of it's targeted based on the patient. If the guy is 66 and he's still skiing every weekend, I don't need to ask him about falls. Of course he falls. Everyone falls when they ski, right?
Oh, goodness.
So I think instead of making it a blanket where you waste all your time going through these checklists, it's better to personalize it. And I think people appreciate that too. They don't want to be asked about something when it's not relevant or it's even considered kind of stupid to their case.
So I want to disclose that because of who I am, I feel truly inferior at this point to Dr. Scott.
It's just different stuff. It's different.
Listening to John, I think at least the way I hear it is, John is just grounded. I mean, there's nothing unique. He's describing, just reality. Reality is that not every job's perfect. And in fact, if you're having to deal with a lot of hassle, you may even better understand the hassle of your patient who's a mechanic or the guy who's working at a restaurant because, everybody goes through shit. And it's just the fact that John isn't taking things for granted. He understands that, like, maybe he's not making as much money as the dermatologist or the plastic surgeon, but he's doing all right. Like, he's not on the breadline. If you were to look at his almost any physician's salary, it's up there, pretty high compared to what most people earn. And the reason I thought it was helpful to bring John on today is because when you read Dr. Rosenbaum's essays, there's a lot of hyperbole about how the whole system is dying or dead, and perhaps primary care is not even worth saving. What can we do? Is there any hope? And then you just have down-to-earth people providing fantastic care. And in fact, while he was talking, I was just Googling the reviews that patients write. I don't know, just looking here, one of them says, over the years, I've had several primary care doctors, both men and women. Dr. John Scala has been the absolute best doctor I've ever seen. He's up to date on the latest treatments. He's also truly engaged and devoted to helping me with all my health concerns and needs. When I needed a specialist, he connected me with a network of professionals of the highest caliber that could be obtained. He stayed engaged in the treatment, and he personally calls me at home to report test results. And, John is just somebody going to work who, like I said, appreciates the opportunity to be helpful to people, who's got skills to do that, who doesn't expect every day to be perfect, who enjoys the moment, who cares about his patients. And yet, reading Rosenbaum's essays, you would think that was some sort of Martian. And I don't think it is. I think there are quite a few physicians out there who are doing this. Now, I do think we have to look at this from two perspectives. One is the reality that a lot of the concerns she raised is about the system crushing primary care are all real. They're true. And John is affected by them. He just doesn't let them ruin his life and his work. And I think the other issue is the fact that we're not producing a pipeline of people into medicine who are just basically somebody who lives by their values, who's pragmatic, and who cares about their patients. There was this argument for years that the reason we don't have enough primary care physicians is because medical school debt is so great. And all these medical students like, I have to go into plastic surgery because, I'm going to owe $500,000, et cetera. So NYU and a small number of other medical schools had huge donors and were able to make medical school free. The tuition is zero at NYU, for instance, and at some other places. And as Dr. Rosenbaum points out, the percentage of graduates going into primary care actually dropped. In fact, it's half the national average of people going into primary care. And so it was just a farce. It wasn't true. And so I think we have to ask a deeper question of, even when we eliminate medical school debt, why aren't people doing it? And doctors could say, well, I just don't want to be somebody who's making referrals, and that's all I do, or who's asking people about bath mats and stuff like that. And well, no, I mean, look at John. That's not how he spends his day. So I think we have to get to deeper questions. And as you know, I've been doing a lot of research for 20 plus years, audio recording doctor-patient encounters. And what we hear is an enormous amount of just what I call efficient task completion. Just somebody sitting there looking at the computer and just not connecting with the person in front of them, not connecting with their patient, and not knowing how to do it, and getting obviously sucked into the system where they're trying to basically please the computer and please the system, and they don't really know how to engage with the patient. And so I think that's something we need to talk about. We need to talk about the fact that maybe we're not actually preparing most people, to be effective at primary care. So it's coming from both ends. It's that the system is a problem, and it's that the system of training people and selecting them and the acculturation of them is a problem. And I think those are, to me, the high priorities for discussion.
I mean, John, I was trained to think in terms of differential diagnosis, and the people I admired most were the ones who could diagnose the most interesting problems. What I esteemed to be was the person who could lay out the functioning of the nephron and how urine was concentrated and how problems occurred. I also knew that I liked talking to patients. Is that how you looked at medicine? Do you think you had a slightly different drum beating in your head compared to what I just described about myself?
No, I mean, I think that's kind of how we all are. I mean, I wanted a deeply cognitive but personal and face-to-face situation. And so, like in my office, historically, I had a paper chart in front of me, and I'd be writing on there, and I can look through the chart. And then we had this EMR stuff come through, and I've been doing it almost 15 years now. And so I didn't want to kind of be on the computer. I thought it was kind of rude to not be looking at someone when we're talking.
Yeah.
And so I kept using my clipboard, and I'd write things down and I'd talk to them, and then I'll go back and dictate it. And so there's this kind of deep thinking and concentration, for me at least, or maybe I'm just slow at everything or not a good typer, where you can talk to them and write it down and be kind of observing them at the same time. You're chatting with them, you're observing them, you're watching how they are. And then, the computer's in there. I'll say, I don't want to be rude by not looking at them. So I'll say, oh, I'm checking your blood pressure. Or, oh, I'm, looking at the radiology report or something, and then I'll turn back to them. So I just always like that kind of interaction and then thinking about things.
One element that comes to mind from those articles is that some students are told that primary care is for people who are not rising in the hierarchy. Do you want to comment on that? Is there some pressure to not go into primary care?
I didn't experience that because we were a primary care-based residency.
Okay.
And granted, it was like 30 years ago, but I think there's perhaps across the spectrum, maybe the primary care is looked as, not the brightest guy from med school. But knowing the job now over the last 30 years or the career path, it's actually probably one of the hardest things. Like if you're a cardiologist, at least you know the organ system when someone walks in your office, right?
Yeah.
The rheumatologist and the nephrologist, they're a little more broad-based and it's more challenging for them. Okay. They're a lot closer to us internists, I think. But on a day-to-day basis, I could have someone walk in my office with a life-threatening emergency, and that happens from time to time, like, oh my gosh, right? Clear the halls. Or the majority of stuff is just routine stuff, and sometimes they just have to go home and rest. Sometimes they just want to chat. And so it's the essence of medicine. Primary care is the way I always thought about it, where you're the one that gets to do the original diagnosis. If you're in the ER, and those guys are great, I'm going to tell you, but you have tons of resources. You have x-rays, you have labs, you have people to help you and stuff. When you're a hospitalist, tons of backup. Any x-ray, any lab, any specialty, any procedure you want is always there. Maybe not in the smaller hospitals where I used to work. So you're working with a situation where you have to use your best judgment with a lot of uncertainty. Okay. And so I wanted to be that guy that could figure it out most of the time, kind of on my own without much backup based on, all my reading and experience. So I've seen probably like 120,000 outpatient visits by this point in my career. And so I wanted to assume the responsibility of all the parts of the patient, all the different diagnoses, and then just, refer out when, I need a procedure or special tests or maybe just a higher level decision process by a specialist. And so that's always been my goal. I don't know if that's for all primary care. Some of the older internists here that I know, they're kind of like that also, but I don't see it coming through the pipeline like that.
Yeah. So we don't see it coming through the pipeline. So I'm curious if you see this as a situation where we need to rescue primary care, or do we need to simply listen to people who do it well, people who understand what they're doing and enjoy it, like John? Do we need to re-engage the training system in a way to help make sure that many of us grow up to be a bit more like John than perhaps some of us did?
It reminds me of there's a place where Dr. Rosenbaum writes in one of her essays, quote, "One challenge in writing about primary care's demise is gauging the professional mood. How much does anyone actually care? Though specialists lament patients' access challenges and seem disinclined to do the PCP's work, outside primary care, I sense little motivation to advocate for its sustainability. Perhaps medicine's corporatization has left us feeling defeated. The profit motives seem insurmountable, and given the expense of employing physicians, primary care may be the first mass casualty." So the way I read this is she's saying, look, the specialists don't value primary care other than the fact that the shortage presents access issues. They wouldn't want to do the kind of dirtball work that primary care doctors are doing. And so primary care may be the, quote, first mass casualty because nobody except people in primary care seem to care about it. And I'll take her at her word here, but it's really important to think about what that means, which is that the profession itself, the specialists, the non-folks in primary care, don't get it and have a disparaging negative attitude towards it and aren't even sure it should prevail. And I think she's struggling with that as well. She's struggling with whether she agrees with them or not. And that she ends with this question of, who do we want to be? And I just think that we have to answer the question of what does it mean to be a doctor and what is it that patients want and need? And I think that what people like John reflect is it's getting up every day, going to work, and helping people one person at a time solve the challenges in their life related to their health and healthcare. And that's what it is. And, there are pressures that are on the primary care to have rapid throughput. And, if you want to make more money, we'll give it to you if you document all kinds of stuff. But when you clear away the dust, what you have is what John does every day when he gets up and goes to work. And these essays reflect, it's almost like the whole system's thrown up its hands and bought into this corporatization. And it's just that you're not seeing it, you're not appreciating it, and you're forgetting what medicine is for. And so that's where meeting folks who are just in the trenches doing what John does and enjoying it, and that's kind of the reality check.
Yeah, I identify with that. But I suspect somebody listening to this, though, will say, no, I'm being crushed. I wanted to do all the things that John does, but I'm being crushed where I work. I'm being told I'm inefficient. I'm being told I'm ineffective.
I want to ask John about that. John, you mentioned spending a half dozen years in a corporate setting and realizing this is not working. Can you say a little bit more about that? And
Yeah.
Do you feel like it's possible to practice primary care the way you practice it? Or is it only possible when you break away from it and create your own practice?
I think I could have kept on with the corporation. It's just that I've got a really kind of strong independent streak. And, it annoys me when other people think that it should be a certain way. And it's like a bad teenager almost where you have to do it yourself. And so I had the experience to be able to do it myself. And I just wanted to do it my way. I didn't want to be that guy at, 65 or 70, look back and said, I wish I'd done this. But, looking back, say this practice becomes non-profitable. It's been very difficult with the inflation the last 5 years. The payments, because I've been tracking them since I started in 2001, the payments are almost the same dollar value as back in 2001. I think I was getting $80 for 99213 in 2001, and now I get $85.68.
They gave you a boost.
Yeah, exactly. But like
In
the
real dollars, that's a loss, right?
yeah. I mean, the salaries I pay my staff now are, probably double what I paid back in 2001. And the rent costs more and the medical supply. I mean, everything costs more. But in reality, when you read the articles, it's like a 30% cut from Medicare. And those quotes, those numbers I quoted were some of the higher payers. It would have been like Blue Cross or United back in 2001 and again here. So at a certain point, if they continue not to raise the reimbursement, it won't be viable unless you're working like 12 hours a day, which I'm not going to do. I'm not going to work 12 hours a day seeing patients. So definitely I could still do the corporate structure if I needed to. I just have to just suck it up as one of the other annoyances of my job. But it's definitely doable. And it's a lot more planned. Like you have your preset salary and you're going to get it every time. And all the annoyances that happen in the office, you don't have to worry about that because someone else is doing it. You have other annoyances, like having your medical assistant traded out every year.
Yeah.
But you just trade one annoyance for another, basically.
Yeah. You pick your annoyances as well as the things that you resonate with.
But in this situation, when I'm on my own, if it's an annoyance, it's my annoyance because it's my practice. And then I just live with it because I know I don't have a choice in that certain thing. So I don't know. There's, two types of PCPs I see kind of developing. There's these like complex PCPs, I call them, where they really kind of manage everything. And then there's the kind of referral PCPs that do like, the basic stuff and then refer out for most of the stuff. And let me tell you, I'm not the only one like doing it like this. There's thousands of PCPs nationwide that are probably even more experienced than I am and doing a wonderful job. I'm still working to get to their level. Okay.
Yeah. One thing that's emerged, I've noticed, is that a lot of these primary care practices have tried to figure out how to boost revenue with, I don't know what to call them, sexual enhancement, testosterone, injections of this and that, IV electrolyte, etc. It doesn't sound like you've gone for any of that. I am just curious how an independent practice comes to the conclusion that they would want to become a sort of
wellness center.
Yeah. Thank you. That's the right word.
Yeah. So I'll tell you a story. So I was flying for whatever reason, I can't remember, from Utah back to visit my parents in Chicago. And so I was sitting next to this gal, and she was one of these people that sells vitamins. And she found out, I was working in the primary. She's like, oh, I can set you up. You can make a ton of money selling all these vitamins to your patients. And I took her card or whatever. But, then kind of thinking about it, I'm like, you know what? I'm not going to use my medical knowledge to trick people. Even though there is some benefit to some vitamins, for the most part, it's kind of tricking them into spending money. And I know I could make a lot more money doing that, but I just, that's just not my way.
Yeah.
To get back to your earlier question, Stefan, about the training system, I feel like our medical education system has been corrupted, or maybe it always was corrupted, but it's increasingly corrupted by the capitalist environment in which everything is driven by dollars and also grant money and prestige. And again, I'm not trying to just point the finger at Dr. Rosenbaum. She makes many important points, but it is a kind of ivory tower. And in that world, primary care is low on the totem pole, and there's questions about whether it's, it even should survive. And there's a lot of technical conversation about structural issues. And in that environment, it's very difficult to produce good future primary care physicians. When people come through that system, we just create this pipeline that's driven by multiple choice tests and, getting the best possible scores and then being told, oh, wow, you could be a dermatologist or you could be an orthopedist, or just all that kind of stuff. And then you go from there into internship and residency where the pressure is to be super efficient, and the efficient one is the person who puts all the data in the computer quickly and just, is always the one, who doesn't slow anyone down. That whole culture, how many people get through that and come out normal? And what do I define as normal? Normal is somebody who is, and again, I'm going to call John normal. Normal is somebody who just understands that they've got a job that involves being ethical, that it does not put money first, where you're satisfied with the reality that not everything's perfect, and you care about the people who you take care of. You want to get to know them, and you're going to use your expertise to help them make difficult decisions under uncertainty, which is something that John talked about. And I think we have to appreciate that all of medicine should be centered around that framework and around the work of that person. The specialists are the consultants. They should be serving the primary care physician, not the other way around. And I think that in the current environment where specialists can even feel predatory to patients, they're scooping in to do their procedures and to do their surgeries, more than anything else, you need, and we did a whole episode, we were talking about orthopedic surgeons doing huge numbers of surgeries that have been proven in sham randomized controlled trials to be ineffective. You need a primary care doctor who just says, no, don't go there. Don't do that. And who gets to know you and who understands that maybe your back pain is due to the grief. Maybe it's due to anxiety, and who knows enough and who you trust enough to listen to, and who protects you from just going down that procedural path. That's what we need. And I think that the question is not, should we let primary care die? If we let primary care die, we completely lost touch with the values of being physicians and of this profession. The only question is, how do we make primary care easier to practice? And especially, what do we do to create a culture that produces people who understand that primary care is caring for people one person at a time? Now, the last thing I want to say is she talks about how maybe nurse practitioners could do primary care, and I think that's worth addressing.
Yeah.
And I'm open to that. I think that anyone who can espouse those values and serve that role. Now, what I will say is when you listen to John, I'm not sure a lot of nurse practitioners have the training to be able to help a patient make difficult decisions around navigating complex medical problems where there are multiple specialists who are saying, do this, do that. You have to have enough knowledge to be part of that culture and to really steward that patient through that complex morass of technical information. And again, I'm open-minded. I have skepticism. There are many people who haven't gone through medical training who could do that. But if they can do that, then that's fine.
Wouldn't rule it out.
Yeah, I don't care what somebody has after their name, what letters after their name. I do think that often that is going to require somebody who has been through the full MD or DO and residency training process. But again, I keep an open mind. I'm not trying to be protective here. I'm just saying that we have to center everything around this idea that people need an expert advocate who knows them, who they trust, and who is with them over time. And that's got to be the beginning of the discussion, not the question mark.
John, you have the final word here.
So I think, and I've seen it in my career, nurse practitioners, even PAs back from 30 years ago, that can perform in most cases as effective as a physician, maybe not on the most severe complex medical case, but at least navigating the system. If you have enough time and enough patient visits, and that's the key, you just, like Saul said, you show up every day, you see your patients, and you do it over and over and over and over and over every day. And eventually you get to know everyone in the area, you get to know all the patients, and you get to know the processes, and that's how it helps things. But I think aside from the whole system side of it, the biggest issue is the human side of it. And we talked about it some during the pandemic. Remember when I mentioned about shaking a guy's hand during the pandemic? Remember that, Saul?
Yeah.
And so the human side of it is what's missing now. Our lives are kind of fractured with the cell phones and the computers. And I think medicine is really fragmented. And the biggest thing that people like in medicine right now is that one-on-one time where you're fully present and you're interested in what's going on and you're trying to help them. And it's almost more important than the knowledge that I've accumulated over the years and experience, that face-to-face interaction in human. It's foreign to people now because of the type of society we live in to have that really close personal attention on a one-to-one basis. And I think if anything's going to happen with primary care, that's going to have to be the focus, to put us back in the humanities sector.
Absolutely.
Yeah, I'm just super thankful to you, John, for being with us and teaching us, and to you, Saul, for helping us put this together.
Thanks, Stefan.
Thank you.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app, as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.